Hi, I'm Mike Kontos, editor for the CardioSource Biomarker website here in Chicago at the annual sessions of the American Heart Association. Today I have Dr. Steve Seliger, an assistant professor at the University of Maryland, who just finished presenting an interesting abstract from the cardiovascular health study looking at a variety of biomarkers in an older population. Steve, can you tell us about your study, some background information?
Yes, we measured cardiac Troponin-T, the biomarker, using a new highly sensitive assay in over 4,000 community-dwelling older adults who were taking part in a long-term ongoing cohort study. The study is known as the Cardiovascular Health Study, or CHS. And we measured their cardiac Troponin-T at 2 time points when they started the study, almost 20 years ago, and within a 2 to 3 year time period afterwards. And we looked at the association of the concentration of this Troponin-T with this highly sensitive assay with the risk of long-term cardiovascular mortality up to 18 years after the measurement of the assay.
And what did you find?
Well, what we found, first of all, was that nearly 2/3 of these community-dwelling older adults, these were all individuals who were free of heart failure but had the typical range of comorbid conditions that come with aging. 2/3 of those subjects had detectable levels of circulating cardiac Troponin-T, detectable at a concentration of at least 3 picograms per ml. Then we found that the higher the concentration, detectable concentrations, the greater the risk was of long-term cardiovascular mortality. In fact, those at the highest concentration, greater than about 13 picograms per ml, were at nearly 3-fold the risk of cardiovascular mortality compared to those who had undetectable levels, the lowest levels. And that was observed even after adjustment and accounting for multiple traditional cardiovascular risk factors and for demographic factors. Then we also looked at how this concentration of Troponin-T changed over a period of 2 to 3 years. And we found that changes were quite common, even though these subjects maintained being a community-dwelling ambulatory population. In fact, when we used a threshold of 50% as a significant increase, we found that over 1/5 of the subjects had that change, and they were at a much higher risk of long-term cardiovascular death compared to those who had no change or a smaller level of change. There was another subgroup, about 50% of the subjects, who actually had an improvement, that is a decrease in their cardiac Troponin-T, and they were at a lower risk, up to about 30% lower risk than cardiovascular death. And again, that was all independent of the major traditional risk factors. Then we also tried to see whether these associations were independent of some of the other biomarkers that have, of course, been talked about a lot, including in the elderly, including N-terminal proBNP and C-reactive protein. And in fact, we found that the associations persisted even after adjustment for those cardiac biomarkers.
I think that's one of the more interesting things about this study. I think other studies have also found detectable troponin in patient populations, but I think yours is one of the first to look at serial changes and looked at kind of the trajectory of change where up and down has different implications. What do you think the etiology for these troponin elevations are in these relatively clinically stable patients?
Well, that's right. As you said, these were patients that were, again, just coming in for their routine study visits, so not being selected on the basis in any means of an acute event of any kind. Based on our information, I think that we can make hypotheses as to what might be correlating or contributing to these changes, although certainly there's a lot more research that would need to be done on a really mechanistic level rather than perhaps on the population level. But what I think we can say is that there's no evidence or reason to think that frank cell necrosis, cell death, is contributing to those whose troponin concentrations are increasing over time. So we did find that there were some correlations with greater LV mass and worse LV function, even within a relatively community-based normal range of those measures. So certainly those may be factors contributing to the release or improvement in troponin. And other factors, I think, have yet to be identified. Any process that might contribute to cell injury without having frank necrosis or myocyte dysfunction, again, in the absence of necrosis, so whether it be oxidative stress or ongoing fibrosis, particularly in an aged population, I think those are factors that need to be further explored.
So these troponin elevations could be a marker for just overall cardiovascular risk or health burden, you think?
I think that is certainly a reasonable way to look at it, particularly in an elderly population, in a sense that it's a sign of some kind of adverse aging of the heart in the most general sense, which has strong prognostic implications for their subsequent mortality and probably for morbidity too.
Well, thanks for that interesting abstract. It does appear that with these newer sensitive assays, we're detecting troponin more frequently in populations. Clearly, more studies are necessary to determine exactly where they're coming from, as well as what the overall prognostic value and additional value is for helping to determine whether we can improve care in these patients. This is Mike Kontos, editor for the CardioSource biomarker website. Thank you.